For those of you who haven't met me yet, I'm Steve Rosenberg. I'm the president of Cochs, and I also want to extend my personal welcome to all of you, and thank you for taking the time to be here. This is a collaborative effort. Cochs is a collaborative effort of convening various partners, and you're all our partners. And I also want to thank Homer and Steve and Ben as well. When we planned this agenda today, we wanted to include speakers and panelists that would shine a light on some of the compelling issues and the challenges of electronic health information sharing between jails and the healthcare safety net. I'm honored, therefore, to introduce Judy Murphy to keynote this meeting. A nurse with more than 25 years of health information experience at Aurora Healthcare in Wisconsin, Judy joined the Office of National Health Coordinator for the Health IT as the Deputy National Coordinator for Programs and Policy just 4 months ago in December of 2011. She has a long-standing reputation of patient advocacy and maintaining a patient-centric point of view, and approaches her work with unyielding energy as well as dedication, passion, and a commitment to the development of healthcare transformation through technology. So I'd like you to please join me in welcoming Judy Murphy.
Great, thank you. Well, good morning. So you probably caught the fact that I've been with the Office of the National Coordinator for 4 months, which makes me a newly diagnosed Fed instead of a recovering Fed. I'm going to start out by framing this a little bit about the patient. I think it's always important when we talk about health information technology to remember why we're doing what we're doing, whether we're talking about electronic health record implementation or whether we're talking about health information exchange. For whatever reason, the work is really hard. You know, it's not like putting barcoding into your grocery store. It's not like automating, you know, the way you pay when you drive on our interstate highways and pay your tolls electronically. It has a lot to do with the people that are providing the care and the people that are receiving the care. And because of that, sometimes we get so focused on the work at hand because it's so hard, we forget why we're doing what we're doing. And so I always like to start out with a patient story. This particular campaign, if you will, that the Office of the National Coordinator has is called Putting the I in Health IT. And essentially what that moniker really means is that whether you're a provider, and we've got some providers that are on this campaign as well, or whether you're a patient, in the case of e-patient Dave here, Dave DeBronkart has been a long-standing advocate for health IT and has actually blogs on it and tweets on it and talks throughout the country about the power of health IT. It's again important to remember that we're doing this for a reason. It's the means to the end. It's not an end unto itself. So it isn't about the technology. It's not about the health exchange or the electronic health record. It's really about the change in the way we provide care as a result of that. I've got a real quick personal story. I've had a friend from college, actually, who has had a long-standing bout with breast cancer and finished a course of a clinical trial at Sloan Kettering in New York about 2 weeks ago and wanted to come back to her home, which was in Milwaukee, Wisconsin, which is where I used to live before I moved here. And in order to transfer her records, she had to have them all printed out and carried them in the car with her on her journey, because that's how today, generally speaking, you transfer healthcare information. I call that consumer-mediated exchange, basically meaning, you know, the patient has to take some responsibility for it. And every one of you has that experience, right, where you have gone to one place and you needed to go to a different place and you had to carry the information yourself. As recently as a month ago, I went and was updating, well, I was getting an eye exam and was going to update my contact prescription. And so I went to the same place I've gone to for over 10 years, and they gave me the infamous clipboard with the form. And was that form filled out with the information from my last visit? Oh no, it was a blank form, and I got to fill it in. Another example, just even within the same organization. And I use those examples because it's not just in the jails that there's a problem here. We have a problem in the country, and it's a problem we're really trying to solve very ambitiously, if you will. So I'm going to give a little bit of background information about exchange in general, and then talk just briefly about exchange and why it would be so important in the jails, although sitting here this morning, I think that has already been done, and why this is so important, the stage has already been set. Before I start, how many clinicians, physicians, nurses? Yeah, when I was looking, there's a few of you, and then everybody else is somehow affiliated. I think it looked like there were some lawyers and some folks who work in the criminal justice system. How many people really understand health IT? You know, like if you looked through that glossary of words, you'd know about half of them. Yeah. Okay. Oh, not too bad. There is a plethora of words, and having come to the federal government, I think they've got a corner on acronyms, quite frankly. But, you know, we're dealing with governmental ones, we're dealing with health IT ones, we're dealing with medical ones, and we're dealing with criminal justice ones. And so hopefully I'm going to do a good job of not using any of those words, but if I do, I will try to catch myself and give an example. Okay, so patient care actually is really at stake. And again, I think the stage has really been set quite well for me here. But here's some other kinds of statistics. 1 in 5 discharged Medicare enrollees are readmitted within a month. So they actually end up coming right back and getting readmitted. That's a pretty dismal statistic. Just in general, in our healthcare organizations, we've been looking at that and trying to really impact that. And in fact, there's some payment reforms around the idea that if a patient is readmitted, quite frankly, Medicare is not going to pay for that second admission. And so it's giving some additional incentives for organizations to look at how quickly they're discharging people and how they're equipping them to manage their own care. But it brings up this point of the health exchange again, because the idea here is that we should be transferring them to another type of care. So whether it's home care or maybe rehab or back to the primary care practitioner, it would make a lot of sense that we're passing the information on to those folks that they need to care for that patient so the patient doesn't have to be readmitted. 40 to 50% of inpatient admissions come through an emergency department. So if the emergency department and the hospital are not on the same electronic health record, what happens? That information does not easily get passed. And that, again, is another example of why health exchange is so important. More than 40% of outpatient visits involve a transition to some other venue of care, meaning if you had outpatient surgery or seen in an outpatient setting, that you would then have to be seen somewhere else. There would be some other care situation that you'd be going into. Referring physicians make the purpose of their referral clear only 74% of the time. Point here is that if I'm a referring physician and I refer to a consultant, 26% of the time the consultant doesn't know why I'm referring the patient. And again, health exchange would help that, right? Health exchange could facilitate that because I would incorporate that into the order. I'd say, I want you to see this patient because. Instead, hopefully, we pass that information on to the patient, and the patient can relay that, but we all know how that works. And referring physicians receive feedback from consultants only 55% of the time. So again, we don't have a lot of closed loops. We have a lot of open loops in our healthcare organization. There, quite frankly, is very little health exchange occurring. The cost of exchange today is very high, and the time to develop is often long. However, because of some of the funding that I'm going to talk about in a minute, health exchange is actually poised to grow fairly rapidly in the not too distant future. Again, meaningful use is a concept most people know. I know it got thrown out in the previous presentation. So meaningful use of electronic health records was spawned, the idea was initiated in 2009 through the stimulus bill, where a lot of money was put in this space to try to encourage encourage the adoption of electronic health records. And part of that money was also put in health exchanges. And again, I will talk about that. But that's where the meaningful use concept comes from. It's a staging, if you will, or a maturation of criteria from stage 1 to stage 3. We are currently at stage 1. At stage 1, there was very minimal health exchange required in order to meet the incentives and receive your payments. But at stage 2, we're really pushing the envelope, and I'll talk about that as well. And when I say we, it's a combination of ONC, the Office of the National Coordinator, and CMS, who have banded together, and the proposed criteria for stage 2 is out for public comment right now. And once that public comment comes back and is all digested, the regulation should be out by the end of the summer for stage 2. And again, the intent in the proposed rule is really to push the envelope and get health exchange moving. And I'll talk a bit more about that. So in addition to that, what's happening, of course, in the healthcare environment is that payment that rewards quality and not just quantity is becoming more common. And because of that, the business case for exchange becomes important. So if you think about an accountable care model as an example, in accountable care, you don't have to do everything as an individual provider or as an individual organization that's part of a community, but you need to make sure that it was done in the community. So if a patient has gone off and had their flu immunizations done at public health or at the mall, or maybe through the Visiting Nurse Association, you as the primary care provider, you as the acute care facility need to know that that was taken care of. So that's going to be part of your quality initiative too, whether you did it as the organization currently seeing the patient or not. And so this kind of banding together, if you will, of communities to look at outcomes has become a very important reason for exchange. Now, that being the case, there's lots of different experiments going on. It got mentioned in the previous presentation or panel. They talked about sustainability. We're really talking about two different kinds of things when we talk about health exchange. There is health information exchange, what we call the verb, and that's the ability to move information between organizations. And then there's health information exchange as the noun, so that would be the physical entity in the state or the physical entities in some states. There are multiples of exchanges, and it's the noun that requires a sustainability. So they have to have a value proposition or a business model that is going to allow them to be sustainable after the federal money that they're currently receiving through ONC and CMS is no longer available, which is after next year. And so it's extremely important to understand what that business model is going to be. Who's going to pay for exchange? How are we going to document the value so that we would be even willing as a healthcare provider grouping, if you will, be willing to do that? Okay, just some quick statistics, and this is we keep a lot of different information, but this is one I pulled out that I thought would be kind of helpful. On the left-hand side in blue, this is discharge information from primary care providers and the time within which that information is actually received. So you can see less than 48 hours is only 27%, and it just goes up from there. Basically meaning then that if a patient then is seen within the healthcare organization or at a partner of care within the 48 hours, the record is quite frankly not going to be available. And that's part of our problem. If we don't capture it in electronic health record up front, there's nothing to exchange, okay? And so if there's a delay from the time that the patient is discharged or leaves a particular venue of care, and that data is not immediately captured electronically, there's the delay. So let's just say they're seen, and then they leave the primary care practitioner, and he does or she does not have an electronic health record, and in fact is dictating their response. Well, it has to be dictated, then it has to be transcribed, then it has to become available, and therein lies some of these delays. So when we talk about health information exchanges, and again, the panel just prior did a really good job of doing that, you really have to have an electronic health record because you want to capture that information immediately at the point of care or at the point of contact, and then it's the data that's captured electronically that's actually exchanged. Okay, so the two really go hand in hand, and you pretty much can't separate them. The right-hand side of this diagram talks today about how the information is moved around, and you can see the preponderance in the faxing, which does not really count as electronic. There are some people that try to make it. So what is ONC's role? The Office of the National Coordinator is an important player in this because we feel it is our job to make the cost of exchange lower and the value of exchange higher. So the idea here is that we're really working hard through standards and the creation of standards, convening people to use a consensus process to get standards documented and adopted throughout all of our healthcare organizations, and through that process drive the cost down, so that we're not looking at proprietary systems where you have to create point-to-point kind of interfaces, where I have to know exactly what you're sending and I have to hard code in how I'm going to have to accept it. But instead of that, we're actually saying there's a standard, and so I know how you're going to send it to me. And I know then how I will package it and send it back to you. So those standards fall into a couple categories. The first is the vocabulary itself. So you've probably heard words like LOINC. That's the standard for how we describe the lab values. RX norm, that's the standard for how we describe the pharmacy medications. And again, as clinicians or as folks who don't work in the technology, it's not important that you really understand the gory details of these standards, but it is important that you understand that they exist, because otherwise, we quite frankly can't take a medication from system A and move it into system B because we don't know what it is, okay? And so again, unless we would tailor make every single interface in and out of every single system, and when I use the word system, I could mean the vendor system, I could also mean the system of care or the particular venue of care that's actually, that we're currently talking about. So again, we're looking at the cost-value equation, and then the other role of the government is to ensure trust. Okay, so there's a lot of privacy and security issues. There's a lot of issues around provider directories and patient directories, so that we know that when information comes and it says it's about Judy Murphy, that we in fact can trust that this is actually Judy Murphy. So it again is similar to what we had to create in our financial systems not that long ago when we started using them on the internet for buying and keeping track of all of our finances and things. But the standards, decreasing the cost, increasing the value, and maintaining trust are all areas that the Office of the National Coordinator is involved with in order to advance or move the ability to do health information exchange forward. Okay, so what are some of the levers that we're using? I already mentioned we've proposed some pretty stepping it up kind of criteria at stage 2, where we're sort of feeling there's an inevitability about electronic health records, and I say that very cautiously. I have lived much of my life, although I'm a nurse by original background, I did move into IT 25 years ago and have been installing some kind of an application ever since. In the 15 hospitals that Aurora has, we had so much fun doing it the first time that we actually decided to switch vendors. So I installed, I think it was 350 individual private practitioners and the 15 hospitals. And then before I left, I had converted 3 of those hospitals to the new vendor. Computerized physician order entry was accomplished as well. And these are, painful things. Dr. Ventures, I think, addressed that earlier about this is a workflow change. If you're really going to take an electronic health record and use it appropriately, it's not just about taking what you had on paper and putting it in the computer. It actually is about using the computer to its max capacity. And so, these are, again, painful implementations. But once you get past that, you start to see the value of having electronic lab results at your fingertips, and being able to take lab results and, trend them over time, or trend them against blood pressures if you're looking at the impact of a vasopressor, for example. So those are some of the things that you start to realize are huge values. Our standards interoperability blocks are, I'll say, in place, but that's a qualified in place. It's not like every standard that we're ever going to need is done, but those basic building blocks are in place. In your glossary, there are a couple of terms that I would draw your attention to, and the first one is direct. Direct is one of the standards that we have proliferated for the packaging up of the vocabulary words so that they can actually be transported and unpackaged by somebody else. Oftentimes, what we communicate in that package is something called a CCD, or continuity of care record. It basically is kind of like taking information and putting it all together in an email, but in the email, there's sort of a wrapper around the email that talks about the information that's inside of it, so that when you receive this quote-unquote email in the receiving electronic health record, that sort of wrapper or packaging can actually decompose the email back into the actual data that was in it, so that when you get a CCD, instead of it being like a blob of data, you can actually take it and know there's lab data in there, and that lab data can be imported into your electronic health record and would actually appear with your other lab data on a flow sheet. So that's why things like these standards are so important. Otherwise, you could look at it and it'd be a blob of data, which of course is better than having to fill out the clipboard from scratch, but it's not really where we want to be. We want to be able to actually take that structured data and import it, if you will, into an electronic health record. So direct is one of the standards that we're using. The other one is the Nationwide Health Information Network, or NWHIN. That's a much more robust standard in terms of exchange. So instead of being an email, and the value proposition for health exchange using this direct process is, I'm a doc, I'm referring to you, I know you're going to see the patient, I package the stuff up and I send it to you because I know you're going to need it. Okay, that's the common use case in direct. It's where I send it. In the Nationwide Health Information Network, it's really a different kind of standard. It's what we call query-based, so that I would actually go out to an exchange and I would say, do you have any information on Judy Murphy? And if you do, send it back to me. You can imagine the level of standard requires quite a step up from this sort of packaged email with the wrapper, okay? But those are really the two kinds of building blocks that we're looking at using right now. The Nationwide Health Information Exchange governance will increase trust and reduces the need for the one-to-one negotiations. So what we're talking about there is in that query model where I go out and I say, do you have anything? We do have to have governance of the way that we do that, okay? And the two bullets that I put there were digital certificates and data use agreements. They're just really words around the idea of how we would establish trust, so that when I'm asking and then grabbing something that you have put out there, that I trust that it's coming from a source with good, valid information, and that we have prearranged our trust, if you will, in a data use agreement using digital certificates. So I think I'll leave it at that for now. But as you can sort of imagine, this is not something that we could take lightly, because we're talking about protected health information, okay? And there's a lot of privacy and security issues around patients and how they want their data shared as well. And that's another scenario where the government is spending a fair amount of time, is really thinking this through. It is the number one concern for patients that, so for example, if I send information that I know about a patient to you, and then you refer the patient to yet a third party, do you have the right to send the information to the third party that I sent to you? Or can you only send the information that you have now collected? You can see I'm giving you a very simple example of the issue, but you could imagine that kind of compounds itself when patients are moving in and out. I used to think that there's some closed networks where health exchange isn't a problem. I remember thinking several years ago that the Veterans Administration, my father was a vet, and he was seen throughout the VA in the last 10 years of his life, and I thought, this is where it's at. The VA, they have everything. They've got this all figured out because they give you the drugs, so they know what medications you're on and everything. Well, as it turns out, statistically, 40% of veterans are seen at a healthcare organization outside of the Veterans Administration. And of course that varies around the country, but it has to do with the whether there is a VA in your particular vicinity. It also has to do with, in your vicinity, there might be a VA, but they don't do mammograms. And so they outsource mammograms to another organization that does them on your behalf. Well, you can imagine those results, again, have to get back into the record that's used there. So this is a problem, literally, for everybody. It's not just certain kinds of organizations. Okay. So the state HIE program itself, I mentioned, was inaugurated, if you will, through the stimulus bill or the HITECH Act, and that was in February of 2009, and it authorized the establishment of the State Health Information Exchange Cooperative Agreement Program. Now that was one of multiple programs that were initiated at that time. We talked briefly about meaningful use. Some of the other words that are in your glossary that relate to this, so there were SHARP programs, which were looking at some of the sticky wicket issues, if you will, in the use of health information technology. Beacon communities, 17 beacon communities were inaugurated to look at how do people band together in a community and start to do group reporting, and how do you prove the linkage between the use of health information technology and the outcomes that can be achieved. And the beacons have been in existence now, again, for about 2 years, and it's really quite exciting to start look at some of the movement that they're seeing in some of the chronic conditions like cardiovascular disease and diabetes. And again, this is when the whole community bands together. So these are kind of precursors, if you will, to some of our ACO pioneers and those kinds of things. However, back to the state HIE program, there was a total of $564 million awarded to 56 states. So you can do that math fairly simply. About $10 million was given to every state. And there was some variety on that based on the size of the state, based on the proliferation or the number of primary care providers, the number of hospitals, et cetera. In order to get the money, the state, in addition to standing up, if you will, their state designated entity for health exchange, they also had to designate a health information technology or HIT coordinator for the state. Those HIT coordinators sometimes report within public health, sometimes report within government, for example, directly to the governor in some states, and they're working, as you can imagine, some very well and actually leading the state quite effectively, and in other cases they're really not doing all that much, and we see everything and anything in between. What we have seen is through the HIT coordinator, in many cases, sort of a pulling together of some of the programs. So within a particular region, and one that comes to mind is Ohio, Texas, New Orleans, where they're actually taking the beacon communities, the state-designated HIE communities, and the regional extension centers, which was another program that we stood up to help the small providers, and really looking at economies of scale and how they can be helping each other. So again, the money that came through the stimulus bill, although the majority of it was toward this EHR incentive payments and getting organizations to adopt electronic health records, there were all these other programs that are feeding into that as well. And so the health exchanges, though very important, one of the ways we're going to actually get better adoption and use of those exchanges, quite frankly, is to band them together with their communities and the organizations in their state to make sure that these are being used effectively. That being said, in many states, there are multiple health exchanges. In New York City alone, for example, there are 4 health exchanges. Now, I understand that they are banding together and looking at some economies of scale, but the idea, as I talked about earlier, this sustainability idea, is that the business models vary from region to region, state to state, what the organizations are looking for from a health exchange vary. And so I think we're going to see some of the state-designated entities that we have funded through the stimulus bill and the High-Tech Act succeed, and we'll see some probably not succeed. We will also see some that were not funded succeed, and some of those fall by the wayside. So this is a marketplace issue, if you will, and that's why the sustainability becomes so important. Okay, so basically what we're trying to do through the state HIE program is make sure that we support the providers in that state or in that area in achieving their health information exchange meaningful use goals, and making sure that we're promoting innovative approaches to the secure exchange of information. So again, really feeding into the marketplace. And the goal is to make a nationwide health information exchange actually a reality. So I've got some goals on the next slide here. The program goals are to foster exchange networks, to monitor the exchange and to fill the gaps, as well as ensure exchange across networks. Now, what are we actually focusing on in the proposed stage? Oops, I think I pushed the wrong button. There we go. In the proposed rule is to ensure that 3 areas actually, e-prescribing. We think this is one of the most important ones, and actually a fair amount of progress have been made in e-prescribing, but here we're talking about that all prescriptions would actually be done electronically, and they would be not just completed and signed by the physician electronically, but they would be transmitted electronically to the pharmacy, accepted by the pharmacy, and then filled in the software. So no human intervention. No, I send it to the pharmacy, it prints out, somebody takes the printout, turns around and enters it into the pharmacy system, okay? So really pushing on making sure that there's a closed loop with e-prescribing. Structured lab results. Since the standards are pretty good in this area, we think this is the second area that we should be promoting exchange and really pushing the envelope. This is one I think that bodes pretty well when we think about the jails in terms of lab data that had been collected in the community and the ability to pull that into the electronic health record, that hopefully the electronic health record that's used within the criminal justice system. And then last, the actual sharing of patient care summaries. And the idea here is that we don't have to do consumer-mediated exchange, you know, with the paper records, but in fact that at the end of an encounter or at the end of a time transition, during a transition of care, that we'd be able to send the information from one place to another. So again, the idea is to really reduce the costs to protect Medicaid and the fragile safety net, and we talked actually about that in both of the previous presentations, the panel, how important it is to know what was already done so we don't duplicate information. And I don't even have to go through this one because I think this was all said before, how important it really is for jails, along with all other venues of care, to have this capability. And again, I'll remind you that although the title of this workshop is about health information exchange, and we're focusing on health information exchange, that you really can't do exchange without having an electronic health record. So this is really about, you have to install the electronic health record, and when you do that, you will be enabling exchange at the same time. But then, of course, you do have to physically hook up to the exchanges in your communities to be able to get that information. I would say probably the statistics are that the penetration of electronic health records in most healthcare organizations is decent. It's been going up rampantly over the last couple of years. There's some laggards in that, and I think the laggards in that are the jails, and I think also some of our smaller practice primary care providers. If you're a provider that works in a larger organization or affiliated with the hospital, you've probably got some bench strength, if you will, to be able to implement an electronic health record, but there are many, many, many areas of our country, in rural in particular, where we still see not a good penetration of electronic health records. And again, the statistics in your space also sound pretty dismal. And last but not least, the other area that we talk about a lot, so rural jails, the third would be long-term care. We're just really starting to see rehab facilities and long-term care begin to install electronic health records. So these are 3 areas that I think we healthcare government really do need to be focusing on. And then just some really quick ways, and you've got my handouts, that you can stay connected with what's going on at the Office of the National Coordinator. We blog, we tweet, we've got a couple of really good websites. Our whole Putting the Eye in Health IT campaign is out there with some videos and with some case examples, and we actually have patients and providers that do blogs as well and talk about their experiences. So with that, I will close. This is something that we say within the ONC. We have to keep our feet on the ground, but we have to keep our eye on the prize. And basically what that means is there's a lot of down and dirty, nitty-gritty work that's still got to get done. We have to keep our feet on the ground and get that work done. But we can't forget why we're doing what we're doing, and we can't forget that we have to keep looking at the next thing that we need to be focusing on after we get done what we need to get done today. So that constant balance between get the nitty-gritty work done, but remember you're on a journey towards something greater. And certainly the electronic health record and health information exchange is a journey and not a destination. And with that, I'll close. Thank you.
I want to personally thank Judy. I know she had a busy day to take the time to come, and I think that your coming speaks to the commitment of the Office of the National Coordinator to hook those of us involved in criminal justice into the Data Hub. That's what this conference is about, and we really appreciate your personal commitment, Dr. Mastari's personal commitment, and the commitment of the office. And for those of you who are unfamiliar with this space, that's partly why we're here, is to familiarize yourself, and you did a wonderful job of doing that. So thanks again, Judy. We're going to take a break now. I'm a time punctuality freak, so we'll be starting promptly at 11:15. We have a packed agenda, and we want to get to everyone's questions and concerns. So 11:15 sharp. Thank you.